Now we'll move to the session number 2. Imaging plays a vital role. So in this context, I would like to invite the chairperson, Dr. Satish Govind. He is the president-elect of the Eco India Association and also a senior consultant cardiologist and echocardiography specialist, followed by Dr. Johan Christopher, he is the director of cardiac imaging from CARE Hospital, Hyderabad. Dr. E. Prabhu, he is the senior consultant and HOD nuclear medicine and SPECT at Tamil Nadu Multi-Care Hospital, and also he is the incoming president of Society of Nuclear Medicine. Over to the chairpersons to conduct the sessions.
Good morning, everybody, and it's my honor and pleasure to introduce our next speaker, Dr. Elizabeth Joseph. She's a radiologist and professor and head of the Department of Radiology at Christian Medical College, Vellore. She's also the founder president of the Indian Association of Cardiac Imaging, she's focused on cardiac MR and cardiac CT, and she's a very passionate teacher and also a guide for a lot of postgraduate students. She has multiple research publications and focuses a lot of her work on the new T1 imaging, and she has numerous research projects ongoing. She'll be talking about the role of CMR and T1 mapping in heart failure, and she has a lot of original work in this regard. Over to you, ma'am.
Thank you, Johan, for that introduction, and thank you, Dr. Mahapatra, for the invitation. I shall be talking about the role of CMR and T1 mapping in heart failure. So what are the steps in looking at a patient with undifferentiated heart failure, and what is the role of cardiac MRI in it? So the first step is to assess the morphology and the function. Next, to characterize the cardiomyopathy. And thirdly, the risk stratification as well as the management options. So this is how we assess function. First, we look at the morphological features. Then we look at the cine images to look at the wall thickening. And finally, we are able to calculate the LV and the RV function, which is more accurate than in echocardiography. So our next step is to look at different sequences. This is a STIR sequence, which helps us to identify edema. Here there is edema in the septum. This is a late gadolinium enhancement sequence showing fibrosis. This could be a case of infarction. And lastly, we have a T1 map, which actually shows us the signal intensity in different areas of the myocardium. So there is both the T1 mapping, which includes the native T1 mapping as well as the ECV. So what is the difference between the two? Native T1 mapping indicates that we have not given contrast, whereas a post-gadolinium T1 mapping is very similar, except that it is after injecting gadolinium. And ECV is a ratio which is derived from an equation which contains both the T1 map as well as the post-gado T1 map. So how do we interpret the T1 map? I'm not going into how it is acquired, etc. But what is the practical use of this T1 map? It's a quantitative method of measuring the signal intensity of the myocardium. And each pixel directly encodes its T1 value and it depicts fibrosis. So if you look at this, I've zoomed down and one of these areas, and this is the value we look at, the mean value. Here, the mean value is 1159. And this is the standard deviation about which we will not bother right now. The post-gado map is exactly the same, except that it is acquired 10 minutes after injecting gadolinium. And there is this complex appearing equation, which is actually pretty straightforward to calculate ECV. All you need is the hematocrit. And ECV is a ratio which is expressed as percentage. We also need to be aware that control values are important, and each machine has its own control value. So we need to do a study and establish our own controls, and the upper limit of the control is chosen. So we compare the mean value of our patient with the upper limit of the control. So T1 measures characteristics of the entire myocardium, whereas the ECV looks only at the extracellular space, and different conditions have different T1 and ECV values. So why do T1 mapping? Why not just LGE? Because LGE can only pick up focal processes, it cannot identify diffuse processes like T1 can do. Now, LGE, T1, and ECV are predictive of all-cause mortality as well as heart failure. And this was published in JACC. We move on to a few cases to illustrate what I was trying to say. So this 63-year-old female presented with dyspnea on exertion, and her cath angio was normal. This is the 4-chamber cine sequences. I'm only showing some representative sequences, which showed dilatation of the left ventricle, as well as hypokinesia of the septum. So when we talk about hypokinesia, we're actually looking for wall thickening during systole. This is a 2-chamber view, again a cine sequence, and it shows us the anterior and inferior wall, and there is poor wall thickening of the anterior wall. This is a short axis view, so these views are quite similar to what is taken in echocardiogram, and hence it's easy to understand. And here again, the septum is not thickening as well as it should. This is a T2 stir sequence, and it depicts edema, and there was no edema in this case. Enhancement sequence, it stands for contrast enhanced. Inversion recovery. Inversion recovery is the sequence we use to acquire it, and there was no delayed enhancement. I've shown you 2 views, the short axis as well as the 4-chamber view. So we have a case of a dilated cardiomyopathy which is not showing delayed enhancement. So it becomes difficult for us to characterize it into any particular disease process. So does T1 mapping help us in any way? Yes, the T1 mapping values are elevated. So the normal in CMC is 1084, and the value here is 1645. The ECV was also elevated. And so what is our impression? We have a dilated cardiomyopathy with a poor systolic function of only 22%, but there is no scar in the late gadolinium enhancement sequence, which would make us think that there is no fibrosis. But this is where T1 value and ECV comes into picture, where there are elevated values. And this indicates that there is early fibrosis, which has already set in. And therefore, this is a poor prognosis as compared to somebody whose T1 and ECV values would have been normal. So what is the role of LGE? LGV is a safe, clinically effective gatekeeper to cath angio in patients presenting with heart failure of unknown etiology. What about native T1 mapping and ECV? It detects diffuse myocardial disease, as we just saw in this case, and complements LGE. In advanced disease, it can use to grade disease activity and monitor progress of disease. So here is a 47-year-old patient who previously had circumflex stenting. Now he has come with acute chest pain. The RCA was occluded. On MRI, the RCA was viable. And so this is his 4-chamber cine. I will directly jump onto the findings. His inferior wall is thickening well and is not thinned out, indicating that there is viable myocardium. There was no stir edema, but the delayed enhancement sequence showed enhancement in the RCA territory, which looks about borderline, about 50%, but because it is an acute scenario with well-thickening walls, it was considered viable. The ejection fraction was 41%, and this RCA was recanalized. We move on to another patient, a 34-year-old female who had dyspnea and had dilated cardiomyopathy, which was detected earlier. The lab parameters showed that the PT and INR values were deranged. and so were the ferritin and transferrin. The 4-chamber view showed a dilated cardiomyopathy with poor contraction. And this is something different that is picked up on cardiac MR. The intensity of the myocardium as well as the liver is low. It is really black in both SSFP as well as gradient echo images. And there was a mid-myocardial stripe, which is often seen in dilated cardiomyopathy. And this is a different sequence altogether. This is a T1 mapping sequence, which again showed that the value here was really low. 660 is a very, very low MS for the myocardium. This sequence called the T2 star sequence also showed that the patient had features of iron deposition. So the patient had iron overload cardiomyopathy. We move on to a patient who presented with bone pain and Benz-Jones protein were positive. Patient was diagnosed to have multiple myeloma and showed all features of amyloid deposition. So the wall thickness in the LV was increased. The interatrial septum also shows increased wall thickness. There is a diffuse global enhancement of the myocardium, which is very typical of amyloid. LV function was reduced, RV function was reduced. The T1 map was grossly elevated, and this is extremely characteristic of amyloid. So this patient presented with shock and normal coronary arteries. There were lesions in the liver and the spleen. The LV ejection function was low. The anterior and septal walls showed transmural enhancement. The T1 map was normal, but the ECV map was abnormal. PET-CT showed mediastinal nodes as well as myocardial uptake, and a diagnosis of sarcoidosis was made. So in summary, all these steps can be fulfilled in cardiac MR. That is morphology, function, characterizing the type of cardiomyopathy, risk stratification, as well as management in the patient. Thank you.